Hi, my name is Daniela Montanero and I am going to talk about non-sedation or light sedation in critically ill, mechanically ventilated patients. Definition: the practice of sedating patients receiving mechanical ventilation has been standard care. However, published in the last 2 decades have reported that the use of sedative may worsen outcomes in mechanically ventilated patients. A trial comparing daily interruptions of sedation with no interruption showed that the patients had shorter duration of mechanical ventilation and shorter stay in the intensive care unit with daily interruptions.
For years, those of us who have cared for mechanically ventilated patients have taken a very narrow view of success. Did we keep them free of complications, including pneumonia? Were we able to move them out of the ICU alive? Historically, we keep patients on the ventilator heavily sedated, and we rely on a physician's judgment to determine whether patients can breathe well enough on their own. Despite these good intentions, we have learned that this approach carries risks. Months or years after leaving the hospital, patients can be plagued with debilitating muscle weakness. Many patients complain that they cannot climb up the stairs in their home or get back to the activities that they enjoy. They often have recurrent nightmares as their brains replay visions of horrible things that they believe they saw when they were delirious in the hospital. They can suffer from post-traumatic stress disorder, remembering the experiences of lying immobile and not knowing what was happening to them. They may even have trouble thinking clearly at work or simply balancing their checkbooks.
Applications in medicine. A plan of no sedation was associated with more days without mechanical ventilation and a shortened stay in the ICE or hospital than a plan of sedation with daily interruption. The trial was not statistically powered to show a difference in mortality between the trial groups, the no sedation group and the sedation group. A post-hoc analysis show a lower incidence of acute renal failure in the non-sedation group.
Improvement approach. And we're working with hospitals across the country to put them into place. The first set involves creating an overarching protocol to address ventilated patients' pain, agitation, and delirium. For example, once a day, we should assess the patient's readiness to have their breathing tube removed. We do this by interrupting their sedation and allowing them to wake up, simultaneously getting them to breathe on their own without a ventilator. Patients should also be screened every day for delirium, and we should actively try to reverse that. The next set of interventions focuses on getting ventilated patients moving earlier in their ICU stay. Every day, we should evaluate the maximal level of mobility that a patient can achieve safely, and then we should strive to help them meet those goals. This might mean turning the patient from side to side in bed, dangling their legs from the edge of the bed, or even walking the patient within the intensive care unit while still on a ventilator. The third area involves preventing acute lung injury through the use of low tidal volume ventilation, which ensures that the ventilator does not force too much air into the patient's lungs. For decades, we have known that decreasing the tidal volume that patients receive on a ventilator is an effective strategy to treat acute lung injury. Now we know it's also a strategy to prevent complications that can prolong the need for mechanical ventilation and lead to significant morbidity and mortality.
Pros and cons. Sedation during mechanical ventilation improves patient comfort and may help with ventilator synchronization. However, prolonged and deep sedation has significant side effects, including increased duration of mechanical ventilation, impaired neuromuscular function, and delirium.
Now let's look at the adverse effects. An incidence of extubation leading to reintubation within 1 hour occurred in 4 patients in the non-sedation group and 1 patient in the sedation group. If the time limit was increased to 24 hours, then it was statistically significant, with almost 31 patients, that is 9% of the patients, requiring reintubation in the non-sedation group, while only 14 patients required reintubation in the sedation group. Even the accidental removal of equipments like NG tube, art line, central line was significantly higher in the non-sedation group, almost 15% compared to 9%. The no sedation group had a higher requirement of morphine in the first 3 days, and the sedation group received more propofol and midazolam. However, the point that is very, very important is almost 27% of patients who were in no sedation group, they received sedation in the first 24 hours because of the various reasons like delirium, agitation, and all. So if you
Issue apply in Ecuador. In the ICUs of Ecuador, there is no uniform way of sedation in patients suffering from IMP, and the frequency and types of secondary complications are unknown.
look at the sample size calculation, it was done based on this trial which we showed previously. In this, mechanically ventilated ICU patients had a mortality of 36% in non-sedation group and 47% in the sedation group. And they estimated a 5% type 1 error and 20% type 2 error. And they found that they needed around 350 in each group to have 80% power and to show 25% absolute reduction in the risk of death if they wanted to show the difference between the two groups. Now let's see how the study went on. Totally 2,300
Conclusion. In conclusion, among critical ill adults receiving mechanical ventilation in the UC, mortality at 90 days did not differ significantly between those assigned to a plan of no sedation and those assigned to a plan of light sedation, to a level at which the patient was resolved with daily intervention. The plan of non-sedation resulted in non-important difference in the number of ventilator-free days or in the length of UC or hospital stay.
Pediatric intensivist in the Division of Critical Care Medicine at Children's Hospital Boston. And today I'm going to be talking about the use of sedation and analgesia for the intubated pediatric patient. What we're going to do here is describe how we take care of children on a ventilator at Children's Hospital Boston and talk about some of the principles of sedation and analgesia, namely the goals of providing sedation and analgesia to facilitate care, the choice of medications, the regimen of medications to provide depending on the course of the child's illness, and then how to transition to the point that the child can be extubated once their underlying disease has resolved. Once an infant or child has respiratory failure requiring intubation, The use of mechanical ventilation is facilitated by sedation and analgesia in order to maintain the child's comfort and safety. This discussion is going to be about the use of sedation and analgesia in the intubated patient in the pediatric ICU. The goals of sedating and providing analgesia to a child who's receiving mechanical ventilation are several. The main goal is comfort, and comfort is a combination of analgesia, anxiolysis, and amnesia. And then the second main goal is safety, which is to facilitate the care of the patient, be that providing positive pressure ventilation to facilitate gas exchange, suctioning, or other treatments for which the child needs to be relaxed and cooperative. Remember that medications are only part of providing sedation and analgesia.
Thank you, and you can see my video in my social media.